And last but certainly least is, anybody ever use factor 7A? You have? And the hospital didn't fire you? Somebody else had approval? Somebody smarter, like a hematologist or somebody? That's interesting. The last time we did this in New York a couple weeks ago, there was one doctor out of the whole group of a couple hundred people. He had done it 4 times, and I said, well, did it work? He said, no. So I said, I'm surprised that you still have your job at $40,000 or $30,000 or whatever it is alleged to cost. But the fact of the matter is I think we should know about this thing. This stuff is out there. Any of you in the military? And then aren't they using this stuff in Iraq like water to treat these massive injuries that are from these IEDs or whatever they call these injuries that they're getting, kind of thing? And I think anecdotally it's considered to be kind of a good thing to do. But in any case, this is factor 7A. So not all factors are created equal, and apparently some factors are much more effective at triggering the clotting cascade than others, and apparently this is one of them. The idea here is that if you have broken tissue juice being released, that it serves as this trigger, but the fact of the matter is that this jump starts this clotting process because it's a super concentrated version of this disproportionately important clotting factor. And this is made by this NovoNordisk. What kind of name is that? It was originally used for treating hemophilia B, but by far all of the other uses that it's been used are under the category of humane use. And if you look at the list of humane uses, they're all emergency department kinds of things. So it's made out of hamsters and rapid onset, 10 to 20 minutes. You saw it listed twice in the American College of Chest Physicians recommendations for, the warfarin and life-threatening bleed. You have that version, and you also have the British version. Both of them mention factor 7A in those cases. You would think, well, you need 2, 7, 9, and 10 because that's what the problem is. You get 2, 7, 9, and 10 problem, but apparently this stuff basically triggers the process adequately. Rapid onset, 10 to 20 minutes. One of the problems we talked about with fresh frozen plasma is just how quickly does it resolve these 2, 7, 9, and 10 issues? And the answer is surprisingly slowly. This stuff works in 10 or 20 minutes. You don't get any diseases from it, and you don't get any allergies from it particularly. And so the world's literature on this stuff is kind of looked at by paper number 1. 483 studies or papers. 483 papers involving 1,854 patients. That's like 4 patients per paper. So they have these tiny case series and single case reports, et cetera, et cetera. Obviously, none compare it to placebo because in these cases, people are exsanguinating, so they kind of use it. And in the studies that you saw where we looked at prothrombin complex concentrate, sometimes they use it plus fresh frozen plasma plus vitamin K kind of thing. So, but they're not going to be really nice, clean studies on this by any stretch of the imagination. And it's overall viewed as effective for bleeding for just about any of the more common causes. One of the problems with this stuff is considered about this idea of generating clots where you don't want them, and so venous thromboembolic events are always considered an issue. And the question is the risk worthy of the benefit? So this summary of 483 papers said, we calculate the risk of a thromboembolic event at 1.4%. Well, anybody would take those odds and say, fine, that's okay, I'll accept that in the setting of a exsanguinating, life-threatening hemorrhage kind of thing. When you look at page 220, they have all of the compassionate care things. These are like not FDA approved. Just because it's not approved by the FDA, people can study stuff, and if there's literature to support its use, the FDA basically says, we will basically say that you have an approval for this indication if you submit studies for us that shows it worked in that setting. if you don't submit a study for us, we can't say that it's approved for the use, but it doesn't mean that you can't use it. And sometimes you see people threatening you with, oh, it's not FDA approved for this or that. If you have literature that says, well, here's 5 papers that said it's a reasonable thing to do in this setting, then you can do it. Intracranial hemorrhage, DIC, postpartum hemorrhages, warfarin reversal, salvage of intractable bleeding from aneurysms, trauma, surgery, cirrhosis with GI bleeds, Jehovah's Witnesses, hematologic cancers, and you name it, and all that stuff is ER-related stuff. The initial papers here are from I haven't seen any papers from Iraq or Iran or any of those places where they probably have the most experience with it. The first paper is out of the Maryland Institute for Emergency Medical Services, 81 patients, uncontrolled bleeding, journal of trauma, multiple causes for the prolonged bleeding. They brought the pro times down from about 20 to 10 after one dose, no thromboembolic complications. They said, we think our survival was pretty good, 42% in these people who were having what they considered uncontrollable bleeding. And then 3 is another paper like that, is trauma cases. They separated blunt trauma out from penetrating trauma. And these people were bleeding nastily. They were all needed more than 6 units of blood in the first 4 hours. And they randomized them, actually. I don't know, is that ethical kind of thing to do? To placebo or giving them this factor 7A. And they found out that in the blunt trauma patients, actually it seemed to help. In the penetrating trauma patients, it really, really didn't. The most positive number in that study, number 3, is massive transfusions, meaning more than 12 units of blood in 48 hours, 14% with the treatment with factor 7A, 33% without it. But it is not, honestly, a very compelling study. Number 4, postpartum hemorrhage. I mean, you're talking about a scary thing. These are all young women who are basically going to die because of this hemorrhage situation. They had 26 women. Look at the amount of bleeding these women had. 26 women with major postpartum hemorrhages. They lost 1.5 times their total blood volume. The mean blood volume loss was 11.3 liters. 11.3 liters. In the subset of people who didn't get it, it was 8-liter blood loss. Again, huge. And they considered a good response to be something I think you and I would consider to be a good response. It was, you needed less than 1,000 mLs of blood after we gave you this and no further surgical procedures, which is, they were bled 11 liters. We give you the stuff. If you bleed less than a liter more, we consider that successful. And sure enough, this success occurred in 17 of the 26 patients. They considered moderate success in 3. How many of those people had thrombotic events? There was 1 at 17 hours. And they said, well, was the cause of this medication or some other causes? The cost was somewhere between $6,300 and $9,600 for these patients. So, and I think, every once in a while you're going to have one of these and it's like, holy smokes, and you're packing rags up there and everything like that, trying to get things to stop and giving this drug and that drug. This is something, back in your head you might think about. Intracranial bleeding is where it's been used kind of the most in terms of clinical studies. The idea was, well, you get intracranial hemorrhage from warfarin or this, that, or the other thing. If we can make this hematoma as small as possible by rapidly reversing the coagulation process here and getting used to stop this bleeding, we'll make a small hematoma, will result in a better outcome. It makes sense. Smaller the hematoma in your head, the better. Fact is that the first study was positive. Number 5, made a smaller hematoma compared to those that didn't get it. And the mortality, 18% versus 29%, which was statistically significant in 90 days. It seemed to be, oh, this is great. But paper 6 is the same company-sponsored study, but in what's called a phase 3 trial, before it's given approval. And in that trial, the mortality and neurodeficits were not any different. And so it really countered the prior trial. And so since that time, the company has withdrawn its application to have it approved by the FDA for treatment of intracranial hemorrhages. That was released at of a conference that basically that was told about. And then there is these papers that talk about side effects. And basically the side effects are these clotting. And one of the issues is that particularly in the setting of blunt trauma, you may have a lot of vessels that are not necessarily ruptured, but maybe damaged, some kind of crush kind of thing, which may have damaged these vessels. And any place, therefore, that maybe have a damaged vessel that is not necessarily bleeding, maybe a setup for a spot for a clot to form that is potentially going to go someplace where it ought not go. So they're talking about what has been reported to the FDA with regards to this problem. And they talk about CVAs and MIs and arterial occlusions and DVTs and PEs, and they're all in the neighborhood of 30 or 40, each of those in the neighborhood 25, 35 cases. But the fact is we don't know the denominator. So out of all of these 185 thromboembolic events are reported to the FDA, you know, who knows how many people got this stuff. So it really doesn't help you put this in perspective. And a lot of times these people had a lot of other issues that may have been responsible for a venous thrombotic event as well, so it's hard to say, well, the drug was the problem. I mentioned that the first paper, they concluded after that first paper that it was 1.4%, no sweat. Paper number 7 said, in this study, 285 trauma patients getting factor 7A between 2001 and 2005, they had 9.5% of them had thromboembolic complications. And of that 27, 9 were considered highly likely to be related to the stuff because of the proximity between when it was given and when the event occurred. Dr. Greenberg in neurology has this thing about compassionate use. So we want to use it in a compassionate use setting, or potentially use it. And his essay is entitled, "Is Compassionate Use Compassionate?" And he concluded that a benefit that offsets the likely risks of factor 7A has yet to be determined by acceptable standards of evidence. Well, you know, when are we going to get acceptable standards of evidence? I would, frankly, if I had somebody exsanguinating and they were a candidate for this stuff, theoretically, I'd give it and say, I'll take my chances with the venous thrombotic events. Because what are your chances? They're going to die or may die, and I'm going to get some percentage of them having clots, 1%, 2%, 9%, something like that. But you can treat clots generally, and so I think this doctor's point of view in it is, you know, we're talking about people are going to exsanguinate. We're not talking about, well, it could be, maybe, you know, kind of thing at all. What about fresh frozen plasma? You can use that stuff. What about fresh frozen plasma? And they've studied fresh frozen plasma in the setting of these brain hemorrhages as well. Paper 8 says it doesn't work, and in fact may make you worse. This is about empiric fresh frozen plasma. No, this is the one that talks about head trauma. I have another one, I think, that talks about intracranial hemorrhages. This is head trauma. So that everybody is concerned about DIC in the setting of head trauma, releasing into the circulatory system these phospholipids of the brain, triggering the DIC, external limb of the clotting cascade kind of thing. This is an interesting paper. It said, listen, why don't you just start giving them fresh frozen plasma when they came in to abort the development of DIC? And so here's a double-blind study, 90 trauma patients, Iranian study, randomized to fresh frozen plasma, and how much did they give? 10 to 15 mLs per kilo, which is kind of, 15 per kilo is kind of like the dose, which says you're going to be given a fair amount of this stuff. They gave it over 3 or 4 hours. I don't know why it would need to be given that slowly. They found worse CT findings over time with fresh frozen plasma, and that there was some evidence of harm in that terms that there was non-significant trend to increase mortality, increase in the size of the CT lesions, increase in delayed DIC, and increase in poor outcomes, none of them statistically significant. So they said, we don't see that there's evidence to give it prophylactically in head trauma patients, and in fact there may be harm. The University of Virginia is 17 of 26 patients with isolated head trauma and Glasgow coma scores of 8 or less. It's kind of interesting. They found that abnormal clotting factors on arrival in the emergency department, this process of DIC has already begun. None of the patients who had a Glasgow coma score of 7 or greater had DIC, and all the DIC was in 7 or less cases. When they had DIC, the mortality was 53%. When they did not, it was 22%. So this paper said, look at the conclusion of 9. Consider early empiric treatment in patients with low Glasgow coma scores. Well, the thing that this told us was low Glasgow coma scores are clearly associated with DIC, and that DIC is already operant by the time they arrive at your hospital. But their conclusion, consider early empiric treatment, is just pulling it out of the air. We have another paper, number 8, says they did worse when you gave them what they were suggesting that you give there. Factor 7A to reverse warfarin is, number 10 is this expert panel. 3 of these experts worked for NovoNordisk, the makers of factor 7A. And they've concluded, like so has the Brits and the American College of Chest Physicians, that this is a reasonable thing to do in these patients who are over anticoagulated, works quickly, no volume overload, et cetera, et cetera. Cochrane people, the Cochrane collaboration kind of said, restrict use to clinical trials. I think it's probably true, reasonable, except for when somebody's going to bleed out in front of you, where you're allowed to be more aggressive in those cases. You know, as I mentioned, like the people of the ruptured aneurysms, you do all kinds of things where some people can say, oh, you shouldn't have done that. And you call the surgery team in, you ordered all this blood up kind of thing. Look at the mess you made, and it wasn't an aneurysm. But when you save them, you're a hero kind of thing. He said, great job, Frank, you know. The Cochrane people then are kind of on the conservative side, as you would imagine. But, you know, we got these other people who say, use it in life-threatening hemorrhage related to warfarin. So this is probably at your hospital in the same place that is located the prothrombin complex concentrate. They're probably right beside each other, and in God knows where, because it's not there. Hospitals obviously are very afraid of this stuff because of the costs. But I don't think it's unreasonable to ask a hospital. I don't know what the terms are in terms of, well, you get your money back when it expires or something like that. But so I probably have to find out more about it. But this list of compassionate use areas, geez, we have so many of them that relate to emergency medicine. I think we kind of need to have some kind of sense of, is this reasonably expected to be in our therapeutic armamentarium? Any thoughts on that? You're going to stir the pot at your hospital and say, get us some of that prothrombin complex concentrate kind of thing.